Hi all. So in anticipation of our high-risk newborn material for next week, I want to make sure that I give you this last material, which I historically know we won't have time to get to in the actual class, so I want to provide it to you. So we've been talking about newborn screening tests that nurses are responsible for doing before an infant leaves the hospital. And we talked about pulse oximetry screening, and we also talked about a hearing screen. And the third one we talked about was the newborn screen, which was doing a heel stick on the baby on the lateral aspect of the heel. So not central, but the lateral aspect of the baby's heel. And that gets sent out to the state lab in every state. One of the recessive disorders that they test for is something called PKU disease. With PKU, this person doesn't have a liver enzyme to break down the amino acid PKU, and so therefore they have digestive issues. And this needs to be picked up on birth because if it's not picked up on, it can become toxic and cause some form of mental retardation. So this shows you what I just described in terms of the enzyme in the infographic, and it's showing you the actual test that I said. It's not a blood draw on the baby. You do a heel stick, fill these circles with blood, and send it out to the state lab. And it is imperative that this gets done before the baby leaves the hospital. And it cannot be done before the baby hits 24 hours of age. They have to be at least 24 hours old. The next thing is thinking about sepsis in your high-risk infant, and that this baby isn't going to present to you like a septic med-surg patient would. You're going to see that often in these babies, their temp is usually low, which is different than you think of with sepsis. And with them, they're going to be poor feeders because they're really fighting off this infection. They don't have it in them to eat. They can be in respiratory distress and have some cardiac changes as well. But respiratory distress, a lower temp, and poor feeding are what you're focused on here. Congenital abnormalities, and actually before I get into that, I should just say with a sepsis baby, if we're worried about sepsis, we're doing blood work on the baby. So looking for a white blood cell count, doing blood cultures if needed, and the baby may need to go on antibiotics. Okay, so thinking about congenital abnormalities, whatever's going on with that infant hopefully has been diagnosed in utero so that the parents can prepare for what's going to happen. I've been at a birth where the baby was born with a cleft lip, and it had not been detected on ultrasound, and there was this huge period of adjustment that the parents needed to go through because there's grief when your baby comes out and looks anything but perfect, right? Parents are going to say, are there 10 fingers? Are there 10 toes? So when the baby doesn't look as they expected, you need to give them time to adjust. And this is really where you come into play with your modeling, saying, wow, what beautiful eyes the baby has. Help the parents to realize that the baby still is very beautiful despite whatever abnormality is there. And give the parents time to accept what's going on. So this is showing you cleft lip and cleft palate. You will cover this in pediatrics too, but please know that cleft lip, even though that's the one you see on the external, is the better prognosis. People see that and say, but I can see it, I'm so upset by this. It is the better prognosis, easier to rectify and fix. Whereas if they have a cleft palate, an opening in the palate of their mouth, they're going to have a really difficult time feeding, and that's a much harder repair, even though you can't physically see it on the baby's physical facial feature. This is showing you a baby that has cleft lip on both sides. It's going all the way up into the nose. So you can see how now the parents that I'm telling you about from the birth I was a part of that didn't know this was happening, when the baby comes out looking like the image on your left, there's going to be a period of adjustment for sure. So when does it get repaired? Again, you're going to go through this in PD, but for lips, about 3 months of age. And if it's the palate, we really do it by 1 year of age. And again, it has to be done before 18 months when the baby starts speaking. Otherwise, it can affect its speech development. So how do you feed the babies that have a cleft lip or cleft palate? Well, these are called Haberman feeders. You can see the nipple on the bottle is extended to allow that nipple to get all the way back in the baby's jaw and so that it can actually swallow the milk. Mom can breastfeed and put breast milk in here, but that baby isn't going to be able to latch to her chest. She would have to pump the milk and put it in these feeders. The other thing that can happen is a baby can be born with an atresia or a fistula. And again, these will be covered again in pediatrics in depth. There can be a diaphragmatic hernia, so an opening in the diaphragm where the small intestines are above it, as you can see here. And then omphalocele and gastroschisis. Omphalocele is the better projection, but we've covered when we talked about conception and how we deliver or how we develop, that all of us develop with our abdominal contents externally in our umbilical cord, just like this baby on the left. And then they're supposed to drop back in at 11 weeks when we're in utero, when we're 11 weeks old. So with an omphalocele and a gastroschisis, that process just doesn't happen. So the baby is born with their GI contents exposed. If this happens in a delivery, you want to take a sterile piece of gauze that's impregnated with saline, sterile saline, and cover the organs to keep them moist. Never put anything dry on them because it will stick to them, and that's risk for infection and obviously for tearing of the organs. So always a wet piece of saline that's sterile, clearly. And these babies are admitted to the NICU. They don't go through surgery because if you see the size of these abnormalities, we can't just plop those organs back into the baby. Its stomach doesn't have the room for it. So you hang the organs by gravity and allow gravity over time, the ability to allow the organs back into the stomach, which is shown here. So they make an opening, but they don't surgically put all of the contents back in immediately. It would be harmful for the baby to do that. But you have alteration in bonding here, right? The parents really, they can sort of hold their baby, but not fully to the extent that they'd like to. We talked about, or will talk about, screening tests that a pregnant woman is offered that can pick up on any deformities that the baby may be born with. We talked about folic acid specifically being a helpful supplement to take to aid in preventing neural tube defects like spina bifida. But spina bifida is a CNS abnormality that can occur. It can be occult, which is your image on your far left. Sometimes there's like a little tuft of hair or just a depression. And then there are the more common ones where the spinal cord is actually protruding. In these, there's varying levels of not neurological issues, but motor development. So these patients with the myelomeningocele are usually wheelchair bound, have no sensation from the waist down, so need to be catheterized, etc. This is an image of a baby with spina bifida. And here are two more images. And you want to remember that infants born to a diabetic mom are more at risk for this, and also thinking about the fact that this is why we really encourage folic acid in any woman of childbearing age to try to prevent this. And then this, I know you haven't had PD yet, but you will cover congenital heart defects, so you won't be tested on that in this class. It's just setting the stage because it will be coming up in peds. But remember, our nursing task as it relates to newborn care is to make sure the babies are getting their pulse ox screening to detect, like we talked about today, a baby that doesn't have an obvious cardiac defect but will die without intervention. So we need to ensure that we're doing that monitoring and picking up on those babies who look normal but do in fact have a cardiac defect. So you can go ahead and look at the various types of defects there can be. There's ventral septal, there's a patent ductus arteriosus, coarctation, and the other two. And again, you will cover these in depth in P. And when we talked about conception and development, we did say there can be these bands that form in the amniotic cavity, and they really are these fibrous pieces of tissue that if they adhere to a part of the baby will cause that area to become constricted. So you see in the image that the fingers are, in the drawing image, that the fingers are affected and have bands around them. And then if you look in the lower left, you'll see the baby actually born missing those fingers because the blood supply was cut off by the bands, and that was constricted. This is a rare thing. We do see it on ultrasound and we monitor these babies, but we can't do anything once it's occurring to really change it. Once they're attached to the baby, they're attached to the baby. This is more common in women who have had multiple surgeries to their uterus, so people that have had multiple terminations or multiple DNCs for medical reasons or various things are at risk for this. And I will happily answer any questions. And when we meet next week, we will do all the material before this, but I just wanted to provide you with this.